Good afternoon, and welcome to today's presentation, Reducing Unnecessary Testing Using Evidence-Based Guidelines. My name is Valencia Harper, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout this presentation. Please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will include polling questions. We encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our HealthVisions Delmarva PTN YouTube channel. The instructions to subscribe to our channel are loaded in the handouts to today's webinar. We always start our webinar with a review of our learning objectives. And today we are going to start our webinar, and we are privileged to have with us Barbara Vugrinec. Barbara's entire career has been in healthcare. She began her career in the hospital environment with over 20 years of experience in information systems, health information management, decision support systems, patient access, and patient business services. She was a Chief Information Officer, Vice President for over 10 years at BB Healthcare in Lewis, Delaware. Over the past 5 years, Barbara has worked in assisting physician offices with their EHRs, business, and transformation processes. She worked as a project coordinator and practice transformation specialist at Quality Insights of Delaware. Barbara is currently employed as a senior practice advisor at HealthVisions Delmarva. Barbara participated as a board member for Delaware Health Information Network, DHIN, for 5 years. She has her Master's of Business Administration. She is passionate about improving healthcare and patient outcomes. I would now like to hand it over to Barbara to begin our presentation.
Thanks, Valencia. Next slide. What I like to do is kind of come up with the questions to run on. And basically, I have a lot of them here. This is what we're going to focus on during this training session. So what types of tests and treatment are common to your practices that have some potential for overuse? We hope that you come away with understanding that there may be some tests that you guys are ordering that may be ordering too much of. And what are the benefits of implementing unnecessary testing initiatives? I mean, with everything lowering costs, a lot of times it has a lot to do with quality too. So there are some benefits for patient care with implementing this initiative. What tools can practices use to select the tests? We're going to go through that because, a lot of times, you don't know what tests are in the literature that people are overutilizing. What is the process to implement an initiative for reducing unnecessary tests? We're going to try to go through a process. It's kind of hard to decide how to do that. Again, you have your HVD practice advisors to lean on, and they would love to be able to do this with you. And are there specific tests by specialty where evidence-based guidelines have suggested may be unnecessary? And are there practices who have been successful in implementing unnecessary testing initiatives? And we're going to bring those practices forward and review what they have done. And again, we're all looking at MIPS, so will reducing costs have an impact on my 2018 MIPS cost measures? And as we always come in every 6 months to do a reassessment, you'll see some impact there. Next slide. I'm going to turn it over to Valencia that we want to do our baseline assessment because you're going to learn that you always have to do a baseline to figure out if you've made improvement. So, Valencia?
Our first question is going to ask, in your practice, is your practice currently looking at ways to decrease unnecessary tests, procedures, or office visits? Yes, we currently are. Yes, we plan on looking into processes. No, but we are interested. You don't know, or just no. So we'll give everyone a few minutes to collect these responses. We have about 43% that have voted thus far, Barb.
Very good. Let's try to get up to about 75%.
Okay, sounds great. We're about 64% right now, so we'll just wait a couple more seconds. Okay, about a minute into this, Barb, we're at about 68%. We have 40% that said yes, we currently are. 20% yes, we plan on looking into processes. 27% no, but we are interested, and 13% at no.
Okay. Very, very good. Thank you very much. So we have at least pretty much over 60% that are very interested. Well, let me talk about what the frequently ordered unnecessary tests are based on evidence-based guidelines. What we have seen out there is CT scan for low back pain. Whether it's in the ED or it's in the physician practices, we actually see that test being overutilized. And the evidence-based guidelines say, don't do imaging for low back pain within the first 6 weeks unless red flags are present. Red flags are things that, of course, when the doctor examines the patient that feels that this needs to be done. And then when you look at the evidence under using wisely, they will actually tell you kind of what the red flags are. The next one is colonoscopies. Again, there's always discussion about how often should you repeat colonoscopies. And it says, the evidence says, do not repeat colorectal cancer screenings by any method for 10 years after a high quality colonoscopy that does not detect neoplasm. The next one's antibiotics, and we all know about antibiotics. Doctors' offices, I think, are zeroing in on this, and to not routinely prescribe antibiotics for acute mild to moderate, and in this case, sinusitis, unless symptoms last for 7 or more days. Uncomplicated headaches. Another one is don't do imaging for uncomplicated headaches. And again, unless there's red flags. And preoperative medical tests. Don't perform preoperative medical tests for eye surgery until there are specific medical indications. I will tell you, now this will show my age, my first job in the hospital was working in an admitting office, and there were packs, depending upon what the surgeon would be doing, of just basic, these are the standard tests you have to get accomplished for everyone. Next slide, please. Okay, what are the benefits? The benefits in reducing unnecessary testing is improving health outcomes. I mean, just look at the outcomes that we would be improving with, the concern that we have today with antibiotic resistance. Don't order as many antibiotics for patients. So you don't want them to get resistant to that drug. Provide evidence-based care. Well, we want to look at the studies and papers that are written, and we want to know, what has showed in the past of all these tests being ordered have actually improved the outcome for the patient. Improve healthcare operational efficiency. This is a good one, because basically everybody that goes into the ED, they may be in there for several hours. Well, if you don't have to order a CAT scan, and people have to wait for that, but you could probably turn around the length of time in the ED. That would be the same thing as diagnostic and imaging centers. You really want to make sure the right patient that needs that at right time. Choose tests which minimize harm to our patients. Well, with CAT scans, reduction of radiation exposure. We don't want to keep on having our patients have radiation exposure. Again, this will reduce testing costs, and it will reduce healthcare waste. Next screen, please. Next slide, sorry. Well, what's the tool? The tool is the American College of Radiology has developed the role of ACR appropriate criteria. And what that means is the right exam for the right reason at the right time. And that's what this is all about. Next slide, please. Well, okay, how was the appropriate criteria developed? Really, it was a systematic search of scientific literature. The guidelines were accessed through the literature. They were identified articles to retain and remove. There were different authors that talked about the topic, and basically that was kind of like submitted to a larger panel of reviewed. And what they did was rated those outcomes or those specific literature. And this doesn't stay in place forever. Topics are updated every 3 years or more frequently where needed. So it's constantly updated. Next slide, please. Well, the tool is choosing wisely. And I know that your practice advisor probably has come in and talked about choosing wisely if you're looking for an unnecessary test, procedure, or treatment. But choosing wisely is an initiative of the American Board of Internal Medicine Foundation to help physicians and patients engage in conversations about the overuse of tests and procedures and support physician-led efforts. And again, this is physician-led to provide high-value care and help patients make smart, effective choices. So we are trying to get that collaboration, those conversations between the doc and the patient. And you will always know that the patient expects to have scans and things like that. So those conversations have to take place. Next slide, please. The American College of Radiology, they developed the evidence-based guidelines to assist the referring clinicians make the appropriate imaging or treatment decisions for a specific clinical condition. They're employing these guidelines to help providers enhance quality of care and contribute to the most effective use of radiology. And it encompasses over 230 imaging topics, clinical conditions with over 1,100 variants. Next slide, please. If you notice, this was all done by pretty much all your colleges and societies. So as you can see, if you're a neurologist, your American Academy of Neurology was included. If you're orthopedic surgeons, your American Academy of Orthopedic Surgeons were included. So they really did a great job making sure they had the right participations from the society and the colleges by every different specialty. Next slide, please. Well, let's talk about if you went out on choosing wisely. This is an example of low back pain. And the American Academy of Family Physicians recommended don't do imaging for low back pain within the first week unless red flags are present. And in my entire presentation, I always say, what they came up with. But if you go out and choosing wisely, you will find out they will tell you what the red flags include. The red flags include but are not limited to severe or progressive neurological deficits or when serious underlying conditions such as osteomyelitis are suspected. Imaging of lower spine before 6 weeks does not improve outcomes, but does increase costs. Low back pain is the 5th most common reason for all physician visits. So again, this is through the literature. It's been studied, and it has shown that. They looked at everybody who had kind of a CT or any kind of imaging study for low back pain, and this is what the outcomes stated. Now, there will always be a disclaimer, and you can see that these, it will say on there that these items are provided solely for informational purposes. It does not substitute consultation with a medical professional. So patients shouldn't be going out there and saying, oh, well, I don't have to go to my doctor because, these are the red flags and I don't have those red flags. So they need to, still go to the doctor. This is a collaboration between the doctor and the patient. They will also, on choosing wisely, if you go out there, it will tell you how the list was created. I mean, there's quite a few lists by specialty, and it will tell you the sources. You can actually see the documentation of the literature that studied these tests. And one thing that I really, really like is they actually provide patient education. So you may have that patient who's used to coming in for low back pain and is having, wanting to have a CT scan and say, is that something different or whatever? Well, this provides the education, and you can actually go on Choosing Wisely, download the education, and use that to educate the patient. That, through actual evidence, we have shown that doing a CT scan is not always the way to come up with the diagnosis. Next slide, please. Okay, so basically you have identified, if you went out and Choosing Wisely, you identified what tests you want to actually study. So what's the process for reducing these unnecessary testing? So next slide, please. Well, the step one, again, is look at Choosing Wisely. And it's, of course, you can see the site to go to. There's a selection. You can select client list by specialty. So if you're an orthopedic surgeon, you would put orthopedic surgeon. If you're, a family practice doc, you put family practice. And it will then provide you with a list of all those studies that said that certain things, unnecessary testing. Now, it's very important to have your providers participate. You want your doctors to be part of this, at least one doctor to be part of this team, because you need to have it physician supported. You will select the topic and basically then gather baseline data, just like we gathered data today, which was our baseline to see if how many people were involved in doing this at this particular point. And you would get that either through your physician billing management system or your EHR orders to assess your current performance. You can actually, in your EHR, you can actually look at the number of orders that you have done for CT for low back pain. Or in your billing system, and we have had people, and when I show some practices that have done a great job on it, they have got information out of their physician practice management system, which actually shows the number of colonoscopies ordered and things like that. So next slide, please. You need to create a committee and develop an action plan. Again, I would include that lead physician on there, and I would also include office staff, that those that actually do the orders or process the orders, and basically, or schedules the test. And of course, the practice manager. After you've done that, part of the action plan should be educate your providers and staff. You need to actually let them know what's going on. So you want to actually look at the guidelines, come up with the red flags, and actually educate your staff on why you're not ordering all these tests. And the next thing is, again, implement that action plan. It should be, what time you should be doing this and that and everything, and maybe do a flow chart. And basically, if you need to educate the patients, there may be flyers that you would have in your office that you may provide for the patients. Then after you've implemented for at least a month, you need to look on a monthly basis, run ongoing reports. Have we made any change? We got this report out of the system that showed our baseline that we were ordering so many of these tests per month. Now, what are we doing now after we've implemented this change? Next slide, please. Now, there's times when the outcomes have not changed. You need to re-educate. A lot of times, the message hasn't gotten out there appropriately. Either we haven't trained the office staff correctly or whatever, but we need to make sure that if the outcomes are not changing, that we re-educate first, and then we can decide after that, we would actually run another report and provide that data to your provider and staff monthly. And the last step here is we're always coming out to do another reassessment with you guys. So your milestone number 2 will change to a 3. And again, I think that's cause for a celebration. Next slide, please. In this presentation, you can download, if you don't want to go out and choose them wisely, you can actually download a Excel spreadsheet which talks about unnecessary testing by specialty. These are topics that we got out of Choosing Wisely. Now, these are the basic topic, but you have to really go and Choosing Wisely to look at the red flags. I didn't include all that. So I did not do, there's like 5 pages of this Excel spreadsheet. So I didn't want to go through each one of them. And I think that would be boring. But anyway, so I think you can download this and actually take a look at some of these tests and see if you want to choose that as a test you want to reduce. Next slide, please. And this is, again, the second page of it. And again, you can see there is basically family practice physicians, endocrinology, and things like that. So please download the entire document. Next slide, please. Okay, we are now ready for our second polling question, and I'll turn it over to Valencia.
Okay, great. Thank you, Barb. Our question asks, what area will your practice choose to reduce unnecessary testing, procedure, or services? Imaging, lab tests, gastroenterology procedures, medications, or other? So we'll give everyone a few seconds to collect your votes. We're at about 52%, Barb.
Okay, let's see if we get up to 68 again, or 60.
Okay, it looks like we're at about 68%, about a half a minute into this vote.
Okay.
We have 47% for imaging,
Very good.
29% lab tests, 12% gastroenterology procedures, 12% medications, and 12% for other.
Well, this is fantastic. It seems like we have a lot of participants who are really thinking this through. And it sounds like you guys are on the right road of identifying a test that you want to study. So I appreciate that result. Well, what I want to do now is we have a few of our practices who have done a great job and want to compliment them on the job they've done. And I'm going to present examples of reducing unnecessary testing. So next slide, please. We have Nanticoke Gastroenterology. Of course, we identified a cost-saving initiative, eliminating office visits. But you know, when the doctor's talking about his own revenue, that's kind of hard to do. But they really got this information from as a patient satisfier. Their patients were complaining that it was difficult to take off work 3 days. They'd have to take off 1 day before the colonoscopy, then 1 day for the colonoscopy, and then 1 day after the colonoscopy. So it was a patient satisfier that was driving this process. Well, we developed a team-based initiative, created a new process called direct access based on a health risk screening. Now, not all their patients are going to be direct access. It's based on, you know, comorbidities and basically how the patient's health is at that particular time. We were surprised because we looked at the yearly revenue, and this has increased the number of annual colonoscopies. So apparently, patients really love this. They love just going in for the day of the colonoscopy if they meet the health risk screening and getting the colonoscopy done and basically hearing the results and then going home. So I think this, and for this particular practice, they really wanted to increase their revenue, and eliminating the office visit was eliminating some revenue. So basically, with increasing their annual colonoscopy, this was a good thing. Next slide, please. As you can see on this screen, it shows that right now for 9 months, they eliminated $12,480 for the pre-visit and the post-visit. We developed the process between January and March. We started implementing the process beginning April through June. And it took a while because we wanted to make sure that we were all educated on the new process and the new flow. So in the beginning, we only had 1.61% of our patients doing direct access. It went up the next quarter. And right now we're at 7.94%. basically that's the goal when we started out, was to be at least 20%. So we still have a ways to go, but it's moving in the right direction. So direct access has increased patient satisfaction while decreasing visit costs. Next slide, please. Another practice is colon and rectal surgery of Delaware. They were concerned over too frequent colonoscopy repeats. They're basically they came up with, and this is based on evidence, that the average screening begins at age 50. They retest in 10 years if there is no adenomas or cancer risk factors. And they retest in 5 to 10 years if there's small, low risk adenomas removed. And of course, you never eliminate if it's determined by the doctor that the patient has inflammatory bowel disease, large adenomas, and relatives with history of cancer, colon cancer. Next slide, please. Well, they have, this particular practice has 4 providers, and they started off with one provider, and who started the implementation in October of 2016. After about a year, they actually added another provider who was interested in doing that. So as you can see, as you can see, the one that had the most colonoscopies, they were reducing with the blue line. The one that had less colonoscopy, they're kind of staying stable. Next slide, please. And they actually saved $51,000. So our next example is advanced foot and ankle. With advanced foot and ankle, they're a podiatrist, and what they wanted to look at, reducing the number of MRIs ordered by the podiatrist based on evidence-based. And they kind of, the physicians were kind of the ones who actually wanted to do this. They brought it up. And what they decide, don't do MRIs of the foot within the first 6 weeks unless red flags are present. Again, that decision of red flags, you can go in choosing wisely and take a look at what they define as red flags. The doctor defines what red flags is, but they wanted people to try other interventions first, and then after 6 weeks, then actually do don't order the or the MRI. So if after 6 weeks the patient comes back with pain and things, and are having some struggles with their condition, then basically order that MRI. Their year-to-date costs equal about $50,000 for this. Next slide, please. Well, we can't forget about our EDs and our imaging group. We have developed 2 collaborations, one with the Peninsula Regional Medical Center, and we actually developed a group, which we had one imaging doc and one ED doc. And what we did was we had them decide what study they wanted to actually look at. And the one that they wanted to look at was do not perform chest CT angiographies to evaluate for possible pulmonary embolisms in patients with a low clinical probability. And actually, when we developed the group, what you end up doing is you just, at any process, you have to create a baseline. So we actually produced a report out of their imaging billing service, which showed how many chest CTs they were ordering for possible pulmonary embolism. So as you can see on the chart, the baseline that showed up on the report was 293. So there was 293 that they were ordering for possible pulmonary embolism. So as you can see, after we did the first chart review, we educated our ED physicians. And then basically we did post-education, which we did another chart review and produced a report. And we found that only 38 of the cases were showing up. So it showed that we were doing great improvement. You can see the number of ED cases per quarter went down a little bit. But based on that, it dropped from 1.65% down to 0.22%. And we were only reviewing 25 cases. So, and you will notice that in choosing wisely, it actually shows when doctors are ordering CT angiographies that are low value based, scored low value. When we did our baseline, 17 out of 25, which means out of all the charts we reviewed, were scored as low cases. After post-education, 8 out of 25 were reviewed as low. So we still have some work to do, and we still have some probably re-education to do. But what we're going to do is we're going to continue to monitor this. So there was a decrease of 1.43% in the number of chest CT ordered. 68% of the cases at baseline showed low value compared to 32% after educational program. Now, with any implementation that you do, you have to continue to monitor. So right now, we think it's heading in the right direction, but we're going to continue to monitor. So on a quarterly basis, we want to make sure that we don't go back to our the old ways and just order. I mean, there may be turnover in staff, and continue to order those tests without knowing for a possible pulmonary embolism. There was one major thing that we discovered, the doctors discovered, is that basically they should have ordered a D-dimer before they actually did the CT. And that was the education, you know, see what the D-dimer says, and then basically order the CT. Next slide, please. So we also had a collaboration with Bay Health. And of course, we included the ED and we included the imaging. We chose the topic as imaging for atraumatic low back pain. And again, this was chosen by our physicians. We want to make sure everybody understands this is physician-led. And again, they actually look at get involved with choosing wisely. They actually look at the red flags, and when they review the chart, they actually make the decision of what needs to happen. So we saw some fewer low back pain after the educational collaboration. Again, we did the same process. We did a baseline, and then we ended up doing a chart review, and then we ended up educating, and then we ended up doing another chart review. What did we find out? So the baseline showed that 57 showed up on our report. After the post-education, 54. So we percent of total ED cases went from 0.34% down to 0.33, which is not as significant that we wanted it to be. We actually, the number of cases reviewed was 23, and the second one was post-education was 21. And based on the low value score, only 12 of them were scored low value in the beginning and 12 after. So basically, while improvement in the number of low value exams ordered was not realized, the percent of number of CT scans decreased by 0.01%, which equals approximately 2 CT scans. So we went back with the results to our committee and we said, what do you guys want to do? I mean, basically, we probably can improve this. And what we decided to do is we decided that we should establish a goal. You know, maybe, you know, that's all we can get, but let's establish a goal and see if we can actually re-educate our ED docs and make sure that we can then start monitoring it on an ongoing basis. So that's what we're doing. We're each re-educating. We're establishing goal. I think they want to be like at 15%. And then we're going to continue to monitor, and we're going to do hopefully one more chart review to get us on the right path. Next slide, please. All right, as I said in the beginning when we were looking at questions to run on, if you do this, basically the TCPI aim number 2, practice has demonstrated improvement in reducing unnecessary tests. What we need is most of the time when practice managers or practice advisors went into the practice, the baseline always was, most of the time, was 0. So at this one, I think this is the what we see in this was the assessment, the reassessment that we saw in colon and rectal surgery. The first reassessment, it moved up to a 2 because we really didn't see a lot of progress going on. And then after that second reassessment, it's up to a 3. So we're actually, this is a way that you can change and make sure that you're identifying, reducing unnecessary testing, and you can prove it by doing this through a scientific method where you have a baseline and you have then additional reports to show that you have improved. Next slide, please. Okay, we all talk about MIPS, and of course, a lot of us are still, getting our information in at this point. In the beginning, they thought that they were not going to add cost to 2018 category as a category, but it was changed towards the end of 2017. I think in November, October, November, they decided to change it to add the cost, and it was finalized at 10% for 2018. So we're bringing this to you because we really want you guys to know that cost is going to be a factor now. It's going to be one of the categories, and that you need to actually take a look at it. This year, 2017, cost won't be established, but Medicare spending per beneficiary in 2018, basically the cost will be decided on based on, and everybody has had this in their QRUR reports, based on 2 different variables: Medicare spending per beneficiary and or the total per capita cost measures are included in calculating the cost performance category for this year in 2018. So I would ask that everybody gets their QRUR reports and see how well you're doing. If you're not doing well, then I think you need to really take a look at it and see if one of our practice advisors can help you improve that score. There was also a suggestion that 8 to 10 episode-based measures adopted for 2017 MIPS performance period would not be used. They really felt that, well, basically we haven't been studying these things, and we haven't provided the information to our practices, so we're not going to actually just dump this on the practices. So based on that, they eliminated them. I will tell you, because I want you all to get ready for this, the evidence-based, some of them, they're just like bundles, like you did with the hospital systems. They want practices to see results first. And some of the episode-based measures are PCI, knee arthroplasty, routine cataract removal, screening colonoscopies, and simple pneumonia. That's just a couple of the 10. I don't have them all here, and if you need a copy of all of them, we can get that to you. But that's something that if your specialty does that, it's something that you need to look at, because they're going to be paying you based just like on bundles. They pay me one thing instead of charging for that, probably that visit and post-visit and the colonoscopy, they're probably going to combine that all into one reimbursement amount. Okay, CMS is also, as we're speaking, CMS is developing new episode-based measures with significant clinical input. And I will say there has been input because they've had some of the practices actually work on that and provide feedback. And again, I'm hoping and they're hoping that they can allow clinicians to see their cost measure score before measures are potentially included in the MIPS program. But they're always going to be proposing new cost measures in future rulemaking. So the question is, one of my questions was, how does this impact me? Well, again, as you will look at the Medicare spending per beneficiary, it will actually show that if you're decreasing costs in ordering tests, it will show up on that calculation. So anything that you can do to not order tests that aren't for improvement for patient care would be great. Again, we're not asking you to stop ordering tests. We're asking you to take a look at is evidence-based, telling you that you should be ordering that test. So as you know, all know, the government is looking at costs and reducing costs, and we're also trying to make it easier for patients that are really sick. Not that these patients aren't sick, but that need to get in to a imaging center quickly as possible. Because when I was working at BB Medical Center, I was over the scheduling department. We may have had 2 weeks or a couple months to get in to get a specific imaging test. So we really want to make sure that we have the right patients there that really need the test as soon as possible. Next slide, please. So with that, I want to turn it over to Valencia and see if we have any questions that anybody has.
We do, Barb. The question is, in order for us to work on reducing unnecessary testing, activities should be measurable. What would you recommend to small practices on pulling data so we can show improvement?
Again, you can't tell whether you improve unless you have a baseline. So you want to actually take a look at maybe the orders in your EHR and get a report that shows how many, say, low back pain tests you ordered. And you want to start off with a baseline. And you actually want to take a look, say if you do it for a quarter, you take a look at it and you come up with, and again, these are just numbers, 150 that you ordered for that quarter. And then you want to actually go on choosing wisely, and you want to actually take a look at what the red flags are. With doctors and clinicians in your meeting, you then want to decide, well, should we have ordered that test or shouldn't we order that test? And what are the red flags? And when should we order the test and when we should not? You want to create that guideline and educate your practices, or your clinicians and staff. And then you want to basically continue to run reports. And with that education, that should help lower the number of tests being ordered. And it will actually show you that basically you are decreasing unnecessary tests. Any other questions?
No other questions at this time, Barb.
Okay.
I have me, Barb. Cindy has a question.
Okay.
So, question and clarification, Barb. So thanks so much for putting this together for us. I actually learned a little bit today of some things that I had forgotten about, so I thank you for that. One of the things that I'm thinking about is that, last year cost was not a factor in our MIPS scoring, not in 2017. Here in 2018, it's 10%. I believe it goes up to 30% in 2019 by regulation. So, do you have any recommendations or thoughts on that for our practices, thinking about kind of getting ahead of that curve before cost becomes a larger factor in their scoring?
Absolutely. I will tell you that, the regulation says 2019. Hopefully it will go up to 20%, but as 10% is part of our cost for 2018, you need to get this under control, and you need to look at your QRUR reports. You need to see where you're at and work with your practice advisor and see if there's ways that you can reduce the cost. And most of the time it is through ordering unnecessary tests. So if you can actually develop this group and start working on it now, because right now it's only 10%, but in the future, once it gets up to 30%, that's going to be a large percentage, because where they're taking the percent from is going to be quality measures. So like this year, your MIPS categories are basically for 2018, quality measures is going to be 50%. Your ACI measures are going to be 25%. Your quality improvement is going to be 15%, and your costs are going to be 10%. So every year they will be taking, if they move cost up to 20%, they'll be taking it away from your quality measures. And again, we all don't know exactly what's going to happen. We wait till the new regulations are published for 2019. And usually that's not done till the end of the year. So we always ask our practices to be aware of this so that they can actually take a look at this and make sure that they're doing well. And bundling is not going to go away. I know there's a lot of hospitals that have done bundling with their doctors. Now they're moving to bundling with the practice. So their practice has control over it more than working with a hospital. So example of that is colonoscopies. You know, they're going to look at all those things that is included in that cost and all those things that you're charging for and try to get a bundle amount. And they call it episode care. Any other questions?
Thank you, Barb.
You're welcome.
Yes, sir. We do have another question.
Okay.
Would you recommend that we continue to monitor patient satisfaction as we start to introduce these changes?
Oh, absolutely. I mean, patient satisfaction, and as you saw with the nanocode gastroenterology, they wanted this. They really did. They didn't want to have to come in for 3 office visits. So patient satisfaction is very, very important. Again, I would tell you that if you go out and choose them wisely, you will see some information that you can download and educate your patients. I mean, you always hear, you know, patients complaining about the cost. Oh, I went into the hospital and it cost me this much money, or I went to my doctor's office and it cost me this much money. So I think it would be good for you to educate your patients, and you definitely don't want to get them upset. So, and you want to continue with the relationship you have. So I think this would be something that you can actually do on a periodic basis. When we're a practice advisor, we asked our practices to actually monitor patient satisfaction at least once a year. And if you feel like you're getting disgruntled patients, then go ahead and do another patient satisfaction survey and see what the issue is. Because with any process that you implement, you never want to leave the patient out. I'm a very, very much into patient activation or patient satisfier. So you want to really make patient and family engagement high on your priority and keep your patients happy.
Thanks, Barb.
Okay. Any other
Valencia,
questions?
you want to ask that question? Yeah, there's one more. I'm going to field it though. So go ahead, Valencia.
Okay, someone was concerned about the choosingwisely.com site. It comes up with a notice that this domain may be for sale.
Yeah. So here's the answer. It's choosingwisely.org. So it's not .com. It's choosingwisely.org.
I apologize.
That's okay. I wanted to say that. The other thing was I wanted to tag onto that patient satisfaction thing. You know, one of the things that they have out on Choosing Wisely, not only are the clinician lists, so when you go to choosingwisely.org, it will have some things to pick from, our mission clinician lists. So that's where the detail about these specific recommendations are. But then there's also a click for patients. And if you go into the patients one, it's basically information written by Consumer Reports along with these organizations to educate people on what we're recommending. So for example, if we want to work on how frequently we're doing PSA blood tests for prostate cancer, we think we're doing them too frequently. You can download a PDF that's written so that a patient can understand it about, you know, when should you do a PSA test? What is it for? Why is it good to do? When is it not necessary to do? So you can actually print these nice colored handouts to use as patient education. So that's another advantage to the site if you're going to work on these particular initiatives.
Unless there's any other questions, we can go to the next slide, because I just want to make sure everybody sees how you can contact your practice advisor if you're wanting to have help on implementing any of these initiatives. So next slide, Valencia. So here's the list of our HealthVision Delmarva team. And if you're interested, I mean, you probably already know your advisor, but these are people that you can contact to help you with any of this. And Cindy, thank you very much for correcting that issue. I just click on it. I didn't even notice it. So basically, please, everybody, make sure that you look at choosingwisely.org. Thank you. Any other questions, Valencia?
No other questions at this time, Barb.
Okay. Well, then I think I'm going to give, I know practices are so busy, and we have 8 minutes left. So I think I will give the time, unless somebody comes up with a question right away, I will give the time back to you so you can get back to work. And I know you guys are so busy. So anyway, thank you very much for listening to this webinar. And please reach out to us if you need any help.
Okay, great. Thank you so much, Barb.
Okay, bye-bye.
Bye.
Bye.